We'll get started. JP, are you going to be the slide?
Sure, yeah, I can drive. I was chatting with Chris. We can switch over when it's his turn, or I'm happy to continue doing it. So let's see, share screen 2. Okay, can everyone see that?
Yes.
Yes.
Wonderful. So thank you everyone for attending, and thank you to our panelists. This will be our 4th Rover presentation or session. Today we'll be talking about gynecologic cancers and lymphoma. We have a great panel, as well as 2 resident moderators. So we'll start, go to the next slide. We'll have each of the panelists introduce themselves. So we'll start with Dr. Gunther and where they're from.
Hi, my name is Gunther. I'm from MD Anderson Cancer Center in Houston, Texas, and I treat hematologic malignancies.
Hi, I'm Neiman Abavizadeh from Oregon Health and Science University. I'm the residency program director here, and clinically I treat heme malignancies and GI tumors.
Dr. Tao.
Hi, I'm Rhonda Tao. I'm at the University of Utah at Huntsman Cancer Hospital. I'm so sorry, I can't get my video to work. And I can't even figure out how to put a picture up. So, you know, to the med students, you don't have to be super tech savvy to love radiation oncology. You could be like super tech incompetent. But anyway, I treat hematologic malignancies and also GI, just like Nima, here in Utah.
Dr. Bradley.
Hi, I'm Kristen Bradley. I'm at the University of Wisconsin in Madison. I'm also the residency program director here, and I treat gynecologic malignancies. I also treat hematologic malignancies, and lo and behold, also do the pediatrics for us.
Dr. Chino.
I am Junzo. I'm at Duke. I treat GYN primarily, occasionally see other things, but I'm always out of my depth, so I always ask for help.
And I'm Matt Harkenrider. I'm at Loyola University in Chicago. I'm the residency program director here as well. Predominantly treat gynecologic and lung malignancies, but also treat some GU as well. So thanks for having me.
Wonderful. And then we have 2 resident moderators who will introduce themselves and then take the show on the road.
Okay, so hey, I'm JP. I'm a new PGY4 here at Stanford, and I've been doing this with the group for a little bit.
Sorry, I lost you guys. Am I up?
Yeah, we can hear you.
Okay. I'm Chris Stagg. I'm a PGY4 resident at OHSU as well.
Okay, so I guess we could just go ahead and dive in.
Oh, sorry to interrupt, but
Yeah.
just for all the attendees, feel free to you know, submit any questions for the panelists in the chat box, and just make sure it's addressed to all panelists and attendees so everyone can see your questions and see the answers. Okay.
Okay, so case number 1, a 25-year-old woman with no past medical history presents with a persistent cough for 3 years to her PCP. She's otherwise pretty normal in appearance and without significant physical findings. So the fact that it was a 3-year cough was a little strange, so PCP orders a chest x-ray for basic evaluation. And it ends up returning the following. And so we'll go ahead and ask our panelists, please describe what you see on this x-ray, what differential diagnosis may you be considering or entertaining, and then now that we have this, is there anything that we would look for in like a physical exam once we see the patient again?
Want to start? I'll start. So to me, it looks like there's a possibly a mediastinal mass or widening of the mediastinum. And then in terms of a differential diagnosis, I treat lymphoma all day long. So lymphoma would be at the top, but there are other malignant entities that are in this location. So I think there's a mnemonic with thymoma and teratoma and terrible lymphoma and thyroid that kind of you learn in earlier years.
Yeah, exactly. So we'll go ahead and start our first poll question, which would be, what would be your next step at this point? A is an endoscopic biopsy, B is a CT chest, C is let's go to surgery and take it out, and D is evaluation for myasthenia gravis. So let me see if we can start this. Okay. Okay, so majority of people have voted, and majority of students think the next appropriate step would probably be to get a CT chest. So let's see. As part of the workup, they do end up getting, they do end up getting a CT chest, which better delineates the large mediastinal mass, measuring up to 7.4 cms, highly suspicious for lymphoma, and additional enlarged lymph nodes in the anterior prevertebral space. They also get some basic labs notable for a high ESR of 77, normal LDH, relatively normal, although less than 4 albumin, a conserved but slightly anemic hemoglobin, a little bit of a high white count, and a lymphocyte of 2.5. And this is the CT imaging going from superior, middle, lower middle, down to inferior, which we could see the mass with. So perhaps I would defer to the panel for a brief discussion on maybe why you would get the CT before getting the biopsy in this patient.
Yeah, I mean, so I mean, one thing, I mean, I would guess another differential for that anterior mediastinal mass could be a benign entity like a thoracic aortic aneurysm or something like that. So you'd want to know what that is before you stick a needle in it for sure. For radiation oncologists, chest x-rays are great historical images for us, but we love looking at volumetric imaging, CTs, MRIs, PETs. It'll also help, you know, find if you have a where a good target for biopsy for a suspicious malignant mass could be, you know, whether this needs to be done percutaneously or it can be done endoscopically using an EBUS, or does it have to be done surgically and there's no real access other than surgery. So CT is important for all those things.
Thank you. So yep, afterwards they do end up getting a biopsy, and this is in the form of a CT guided mediastinal mass biopsy. So it'd be coming from outside in with a core needle. And the diagnosis returns nodular sclerosis classic Hodgkin's lymphoma, and a subset of histologic features which supports this is predominantly the CD15, CD30 positive cells, which we know are the Reed-Sternberg cells, and it's negative EBV per in situ hybridization. So the next poll question is, at this point, what would be your next step in workup? Okay, we'll give it 30 seconds. So great. Majority of people again voted, and the answer that we're favoring is a PET CT at this time. So perhaps we can briefly discuss why this would have utility for this patient with suspected lymphoma. And here's an image of the staging PET showing the mass, some regional or cervical lymph nodes, supraclav cervical. And this shows no abnormality, but is useful as a reference to show the mean SUV of the liver. So we'll defer to the panel to ask what would be the utility of obtaining this, and what is sort of the basis for why we use the Dovell scoring for Hodgkin's disease.
So a PET CT is really necessary in the upfront staging of Hodgkin's. There can be small nodes that are present on CT, but are again small, and so you don't know if they're avid or not, if they're active lymphoma or not. So PET's really necessary. Sometimes we see that this gets skipped, and it can really affect treatment down the line. Typically, the Dovell score is also critical. On an upfront scan, our radiologists don't usually assign a Dovell score. It's a response assessment. But basically what the use of the Dovell or the 5-point score is it's comparing the uptake in the mass relative to some other internal controls. So the uptake in the mediastinal blood pool and that of the liver. And it's trying to give us a sense of how avid or how active the disease still is. And so we generally consider a 5-point score of a 1 to 3 as being negative. And then, again, that can kind of guide therapy down the line. Anyone else?
Thank you. Yep. So the key take-home points from the actual images that I placed up was, here's the primary in the mediastinum, and then here are 2 lymph nodes that are suspicious in the right neck or supraclav area. So this will be helpful for the next question, which is sort of what do you guys think would be the Hodgkin's staging for our patient at this point? Okay, so most of the participants responded, I believe, and the majority suspect it would be stage 2A. I sort of put A for all of them because we didn't talk about B symptoms, but she didn't have any. And so perhaps we can, but a few people thought it may be stage 3 or 4 disease. So I guess would I be able to solicit some input from perhaps Dr. Tao as to why it would perhaps be stage 2 and not 3?
Yeah, hi there. And I would just add, getting that upfront PET is actually really critical to so much of what we do in radiation planning. And, in terms of the staging, so we know that she has two sites of disease involvement in the mediastinum, and it looks like the low neck or supraclavicular lymph nodes. And so that would make her stage 2, because all the disease that we can see seems to be limited to just one side of the diaphragm. If she has nodal disease, in addition to these sites below the diaphragm, such as some pelvic nodes, inguinal nodes, or periaortic nodes, then she'd be considered stage 3. And then if there's multiple, kind of disseminated disease or bone marrow involvement, or multiple extranodal sites of involvement, then she'd be considered stage 4.
Exactly. Thank you.
Yeah. So, staging in lymphoma is a little bit different than kind of a lot of other staging systems like AJCC staging systems for solid tumors. So that's just one thing that's kind of unique to what we see.
Mm-hmm. So exactly. So for that reason, she is categorized as a stage 2A patient. And so what's important to know for Hodgkin's is that once you are classified as an early stage Hodgkin's, which means not 3 or 4, there is some sub-staging parameters that come into play. So some of the following parameters were already evaluated. The ESR of 77, as noted above. Using the original chest x-ray, they were able to measure a mediastinal mass ratio, which is relative to the thorax, and this came back a little bit less than 0.3. As we mentioned, there are 2 suspected nodal sites, and per what we know so far, there's no evidence of extranodal disease. And the reason I'm sort of laying these maybe perceived as arbitrary facts out, we'll ask the panel about why these may be important and what role they have in helping to stratify early stage patients, either through the German Hodgkin Study Group or EORTC perspectives.
Yeah, so I mean, these parameters that you mentioned are definitely very, very important things to pull out of charts and make sure that you have on all your Hodgkin's lymphoma patients. I mean, it helps us stratify patients for treatment, helps us stratify patients who may be at higher risk for failure, and that in turn helps us kind of figure out who we might need to escalate therapy for. So, in the most common parameters we use, as you've shown, are the SED rate and a cutoff of 50 for somebody with no B symptoms. Anything over 50, we're kind of concerned, and we classify somebody as having unfavorable disease. So for this patient, I might be skipping, I'm sorry.
Yeah, that's perfect.
I can't remember if that's a polling question next, I'm sorry. And mediastinal mass ratio, a typical cutoff that we use is 0.33 or 0.35. And we look at that using a upright chest film. And, more and more people are using volumetric imaging to classify tumors as bulky. And, we're doing that a lot now too. The various cutoffs for that are debatable, 7.5, 10 centimeters, depending on who you talk to. And as well as the more nodal sites you have involved, the more concerned you are for relapse and the more escalation of therapy may be needed. So these are all really important things that help, and there's multiple different stratification consensuses and guidelines from the German group, from NCCN, from another European group that kind of helps us kind of basket patients into these risk stratifications.
Great, thank you. So exactly like was mentioned, because of this high ESR, even without the B symptoms, it's still too high for her to be under the favorable category. So right now she's substage as early stage, still stage 2, but unfavorable. So sort of with that in mind, what may be your thoughts towards your approach to starting treatment? We'll open the poll. Some of these options are not super straightforward, but try to give it your best shot. The first one would be perhaps we'd want to start with mediastinal radiation and then obtain an interim PET. Perhaps we'd want to start with chemotherapy and then obtain an interim PET. Start with a stem cell transplant, or should we start with brentuximab, which is a form of anti-CD30 targeted therapy? Okay, great. So majority of our attendees were able to respond. Most thought starting with chemotherapy would be appropriate for this patient, but some had some thoughts about maybe starting radiation first or anti-CD30 since she was CD30 positive as part of her histologic staging. So perhaps we can kind of briefly discuss the treatment paradigm in general, and then we'll talk about what she ended up getting when she came to us.
You want to discuss just how, so typically patients get started on chemotherapy for Hodgkin's patients. It's usually a regimen called ABVD. And then there is, as was stated in the question, usually an interim PET scan just to make sure that the patients are having an initial response to systemic therapy.
Yep, exactly. So she underwent 2 cycles of chemotherapy first, which is pretty standard for Hodgkin's disease. And so the interim PET demonstrated a partial size and metabolic response of the mediastinal mass. The nodes actually in the supraclav and cervical area resolved. So now she was a dual VEL4 in terms of the primary site. She was offered escalation to another form of chemotherapy called Biacop because she didn't have a complete response, but because she was young and given concerns over side effects and fertility, she opted to defer. So she ended up completing 2 more cycles of ABVD, and another repeat PET showed more partial response, but it still stayed dual VEL4. So at this point, she was referred to us. Jenna, yeah.
There is a question in the chat for one of the panelists. So if the patient has SVC syndrome or a critical airway, would this change your upfront treatment in Hodgkin's disease? Any of you can answer.
I would say it's unusual for us to not start with chemotherapy because these diseases respond so well to chemo so quickly. You know, it's a case-by-case basis as far as exactly what's happening and the urgency of it. But if a person's a good chemo candidate, I would probably, and is clinically stable, I would advocate for them to start chemo ASAP, because starting radiation up front kind of messes up the treatment regimen a little bit, and you're kind of, it's kind of hard trying to patch things in later. So.
Yeah, that's a really good question. And there can be very rare cases where, you know, perhaps it's not even safe enough to obtain an adequate biopsy. And so those rare cases may be, you know, after, of course, a multidisciplinary discussion, a scenario where you could consider giving just a few fractions of radiation to hopefully shrink down the mass so that the airway is not in danger anymore. And then obtain a safe biopsy at that point to kind of decide on what kind of chemotherapy to start with.
Great, thank you. So, well, I might as well just bounce this one over to you, Dr. Taus. So given that she ended up getting 4 cycles of ABVD and didn't have you know, a significant response, she's still dual VEL4, and we still see a mass there, even though it's a little smaller, what therapies may you consider at this stage?
Yeah, so you can, you know, I would be a little concerned that given that she does not have chemotherapy sensitive, you know, disease. So, you know, discussion with her treating medical oncologists about, you know, potentially moving forward with some salvage chemotherapy. You know, but it sounded like, you know, she did not want to undergo kind of the escalated, more toxic Biacop treatment. And I think, you know, at this point, it still is reasonable to proceed with doing kind of, you know, definitive radiation therapy because she still has very localized disease. You know, there's no kind of DOVL5 new sites of disease. It doesn't seem like it's been getting worse. And we have radiation as another modality that is actually perfect for this kind of scenario, where we could treat, you know, kind of the extent of involved disease and even what's currently active disease that's chemo resistant very adequately.
Exactly. So the decision was to proceed with a consolidation radiation to her mediastinum, as mentioned. And so perhaps we can briefly comment on what simulation techniques you might employ and what dose regimen or volumes you may consider prescribing this radiation to. And with the simulation technique, kind of bearing in mind that she's a 25-year-old young woman.
You can take that. So the way that we set up patients at MD Anderson is we have them supine on an incline board, kind of like a breast board. And the reason for using that incline board is that it helps us drop the breast tissue down and away from the field. We have them in a short mask, and we use deep inspiration breath hold technique. And there are several reasons that we feel very strongly about that. It allows us to, it elongates, it increases your lung volume. It improves the lung DBH. It drops the heart down and away from the field when you're normally treating the anterior superior mediastinum. Breath hold also allows you to decrease your margins because you don't have to generate, you don't have to account for all of the motion during breathing. So that's typically how we set up and treat our patients. And I guess I should say we do put, if I didn't mention, we do put arms down as well, which we also think seems to help in avoiding breaths. And then in terms of dose, regimen, and volumes, we use what's called involved site radiation therapy. So that's treating all the sites of disease that were initially present on that initial PET scan. And that's why, multiple of us have said how important it is to have that initial PET CT staging. Consolidation dose is typically 30 gray for early unfavorable patients, but with this patient with a Deauville 4, we would probably dose escalate a bit, at least to that area of the Deauville 4 residual avidity, something around, it kind of depends on what the Deauville 4 looks like and how suspicious it is, but something around 36.
Yep, exactly, thank you. So exactly that, she was treated to 30 gray and 20 fractions to the pre-chemotherapy adapted extent of disease. And what we mean by adapted is like, basically if it was really large and now it collapsed, so there's lung where it used to be, we wouldn't treat frank lung. And then as Dr. Gunther mentioned, 6 gray sequential boost to the residual metabolically avid gross disease. So I guess this one's also a little bit appropriate for faculty at Anderson, but may the panel give their thoughts about the pros and cons of 3D versus IMRT VMAT for the treatment of this patient? And then what about the role of protons for someone who were worried about secondary malignancies?
Yeah, I can talk about this too. Well, caveat that I trained at MD Anderson, so I feel like Jill and I probably will say a lot of the same things. There are times when I'll do a 3D plan. Sometimes we need that for insurance authorization. So I'll do a 3D plan and then usually a static field IMRT plan. And what that means is that basically you have individual kind of fields that, as part of your beam arrangement, as opposed to the VMAT, which means, you're using kind of more of an arc plan. And in almost every single case, the IMRT plan seems to, give us much better sparing of the heart, the coronary arteries, and generally even, high dose areas to the lung compared to 3D plans. When I look at kind of a lot of different plan comparisons, maybe the one case where the 3D plan can actually have a little bit better sparing is kind of the V5 to the lungs. And so what that means is kind of the volume of the total lungs that's getting kind of low dose, like the 5 gray. But usually it's not even very much, maybe IMRT would be just a few, percentages higher than a 3D plan, but everything else, seems to be, much better spared, especially, when we're talking about young patients and we want to really minimize excess dose to normal structures as much as possible. And oftentimes we get much better kind of conformal coverage of, the involved site that we want to treat as well. And, I don't know, Jill, if you guys are using protons much nowadays. But I think, when I was training, we didn't really necessarily have the best kind of image guidance at our proton center. So I think that was a huge limitation. And so without the best image guidance, you kind of have to account for that and increase your margins. And so when you increase the volume that you're treating, increase your margins, then sometimes you kind of negate, the potential, kind of physical benefits of the protons.
Yeah, completely agree.
Great, yeah, thank you, exactly. So in this case, we ended up treating her with 3D. So as was mentioned, there's many pros and cons to either, and you really have to tailor it to your particular patient. But I think for her, we worried about minimizing breast exposure and, as mentioned, the V5 to the lung due to her age. And we thought we were able to treat the region of interest fairly well with an APPA and allowing for this sharp dose fall off to the sides. So this was her plan going from superior to inferior. And this brings us over to case 2. So not sure if Chris, you'd like to take over.
I just want to point out Dr. Dyke is on Mount Hood right now. That's not just a picture behind it.
Oh, okay.
It's simulcasted from the mountain.
So
1 second, my for some
I'm
reason my
happy
computer's
to
giving me a hard time.
keep progressing here. If
Yeah, maybe start and
Yeah.
I'll take over once my system preferences get fixed.
Sure. So case number 2, we have a 39-year-old who self-identifies as female. She presented with intermittent postcoital bleeding. So the first question to our Gyn panel is, what parts of the history would you want to know about for a relatively young woman with postcoital bleeding? And what are key parts of the social history and how this relates to minimizing treatment delays?
So I think this is Junzo. I think, obviously a good history and physical is important for all patients. And I think the first question I would have is, what's her prior history with GYN? Because there are plenty of reasons to have postcoital bleeding. And there are a lot of, social concerns that can intersect with diagnoses associated with these. So it's important to just get an overall sense of the patient's, social situation, et cetera, because treatment delays are obviously something we don't want to, I might see where this is going. We obviously want to minimize any treatment delays. Of course, it's also important. There's a lot of reasons why people are disenfranchised from the medical institution in general. And if we're thinking this might be cervical cancer or something like that, there are a lot of historical reasons why certain parts of our society have been disenfranchised. And so I think being aware of that, and more than anything else, trying to be supportive and trying to make sure that a patient is able to get whatever therapy or not they might need is going to be important.
Yeah, that's a very important point.
I'm back, JP.
Oh, yeah, sure.
Okay. So the physical exam reveals a barrel-shaped cervix and a friable mass from 3 to 9 o'clock position. And so, Dr. Harkenreiter, would you be able to describe your comprehensive gynecologic exam and how you detect parametrial extension, and also
Sure.
how this impacts your management?
So specifically sticking with the gynecologic exam, first, good lighting and visualization is very important. I am very cognizant to talk my patient through exactly what I'm doing, because it's obviously very sensitive and traumatic, especially as you're examining a patient with a new cancer diagnosis in a very sensitive area. Using an appropriate size speculum is appropriate, but first examining the external genitalia, identifying any vulvar or distal vaginal lesions, identifying the location of the urethra as well. I start with a speculum examination, assessing for discharge of blood within the vaginal vault, having packing and forceps available just in case you encounter bleeding is wise. That's one of those mistakes you may only make once in your career, when something starts bleeding and you're not prepared. But getting good visualization of the cervix. In this scenario, you have a friable mass, but a barrel-shaped cervix, which is usually kind of big and bulky with an internal component of disease. Assessing the location that it's that the disease affects the cervix, and then looking for extension to the vagina, describing both the cervix and the vagina as a clock face, and then kind of estimating upper third, lower third, middle third, lower third, when describing any vaginal wall involvement. We'll then similarly do a digital exam of the vagina and cervix, similarly describing the findings there. The rectovaginal exam is really important and is something that until you get a good exam is hard to really realize. So I will keep my first finger on my dominant hand in the vagina, introduce my middle finger on the same hand into the rectum, and try to feel with the anterior aspect of my second finger for the cervix. It usually feels kind of like a firm rubber bouncy ball, if you remember those from your childhood. And I'll swing my finger towards one side, and if I can get around the cervix normally, then that's no parametrial involvement. But if you get some firmness that's tugging you laterally, then that is parametrial involvement on that side. And if your finger can't quite get around that firmness and you feel the cervix being tugged all the way as lateral as you can feel, then that's pelvic sidewall involvement. We'll then do that on the contralateral side as well. And then be sure to kind of tell the exam as a story as you went through it. Try to do the same thing each time. And we routinely are drawing cartoons where we have these visualizations in different planes to thoroughly describe the clinical examination in a pictorial format. Helps document your clinical exam in a few different ways which can be very important to reference later on.
Thank you. So we did feel left-sided parametrial extension. Go back. And a biopsy performed at the time reveals invasive squamous cell carcinoma, poorly differentiated. And so, Dr. Bradley, could you describe what you see on the PET-CT that was ordered, and if you would order any other studies?
You bet. So we're looking at axial slices of PET-CT, scrolling through them. And what we're looking for, any bright areas or hypermetabolic areas. As you guys know, some of those can be normal, like the bladder is going to light up, but we're looking for other areas. And you can see the bladder there anteriorly, but just posterior to that, you're seeing activity in the cervix, the cervical tumor. And then we're also looking, I'm looking for, are there any hypermetabolic lymph nodes, particularly looking along the pelvic sidewalls. Sometimes you can be fooled, particularly in cervix cancer patients. You can see some bright activity laterally, but it may turn out to be the ureter, particularly if it's a little bit dilated from it. And then I'm also just looking down distally to see whether there's any vaginal extension as well. And this study in particular, you can actually note if you go up a little, stop, go back, there. You can see that there's actually, it looks like a couple of fiducials that have been placed as well. We'll often use those if someone has vaginal extension to mark how low down in the vagina the disease extended, which can help then for later treatment planning. And so you can, and that's what a typical appearance looks like. In addition to getting a PET scan, I also routinely recommend that you get an MRI of the pelvis. It can just add some additional information about local disease extent. Often either bladder, rectal, or parametrial extension is better seen on MRI than it can be sometimes on PET scan.
Great, thank you. So our first poll for this case, what's the standard curative treatment for bulky, locally advanced squamous cell carcinoma of the cervix? Looks like JP, I'm not able to see the results. But Dr. Shino, would you be able to comment on the general treatment paradigm in cases such as this?
Yeah, so this is a patient who has 2B disease with evidence on physical exam of extension laterally, and the PET scan really confirms that. You can get an MRI to look again as well, but it's going to confirm all of this. And to be honest, given the physical exam findings, even if the MRI were to be, questionable, I still think it's reasonable to do definitive chemoradiation with high quality brachytherapy. What you don't want to get in a situation is where you're operating on a lot of these patients and needing to do post-operative radiation therapy for cut-throughs or something like that, because while actually the cure rates may be similar, your problem is going to be is that your toxicity is going to be a lot worse if you combine unnecessary modalities, particularly surgery plus chemoradiation. Their toxicities are going to be a lot worse. And so you're not doing your patients any favors by doing surgery up front for them. So really chemoradiation plus high quality brachy is the way to go.
Great, thank you. So as you said, this is a 2B cervical cancer. And since there was a recent change in staging, perhaps Dr. Harkenreiter can comment on some of the global health considerations in this disease as staging recommendations are made.
Sure. So in the US, we're I guess fortunate that cervical cancer is somewhat of a rare cancer. There's in the ballpark of 10,000 or so cases still. So it's still a significant problem, but it's much greater of a problem internationally, especially in low to middle income countries. And those patients are affected much greater with less screening, less access to vaccinations, and then less access to high quality centers on top of that. So it's really a huge worldwide problem. As such, with regards to staging, the staging system had to account for that and really have a universal language. And that's where the FIGO staging system for cervical cancer historically has been, in that we would stage a patient clinically using only limited imaging modalities of lymphangiogram, chest x-ray, and then we were allowed to use cross-sectional imaging, whatever we had, CT, MRI, simply to identify if there was hydronephrosis. So it was really a clinically based staging system, but that didn't account for lymph node positive disease, which is a huge risk factor and prognostic factor in cervical cancer. So just recently, the staging system was updated to account more broadly for modern staging with cross-sectional imaging, to incorporate MRI and PET scan and acknowledge the lymph node status as part of the staging system.
Great, thanks. And we already actually discussed this question. And so I think we're up to Dr. Bradley again. How do you counsel these folks prior to initiating treatment?
I think one of the most important things, because there is a big laundry list about complications and side effects with treatment, is to preface it and emphasize that cervical cancer is often a highly curable cancer. And although they may have side effects of treatment, to keep the end game in mind of curing their cancer, and that you're going to follow them longitudinally over the course of the rest of their life, or for a long time, and be there to help them with side effects if they do develop. I tend to break down side effects for patients into kind of the more acute short-term and long-term, and also, emphasize that it can be a combination of both the radiation and chemotherapy, but that some degree of tiredness, change in bowel habits, whether it's nausea, diarrhea, fecal urgency, Cramping is pretty common. Less common, but you can see, particularly at the end of treatment, is urinary side effects. So dysuria, urgency and frequency as well. If you have someone who has lower vaginal extension and you need to treat lower down in the vagina and include the lymph nodes in the groin, then you can often see some dermatitis similar to a sunburn in that area as well. Fairly commonly, they may also have some cytopenias or electrolyte disturbances. So with the chemotherapy and the radiation, it's pretty common that they may end up needing to get extra potassium, magnesium during the course of treatment. The kind of later side effects, typically, the fatigue, the urinary bowel symptoms, for many people are going to gradually resolve. I tell my patients to not expect a day-to-day improvement, but after treatment, it's more like every week or two, they should be feeling better than the week or two previously. But for some patients, side effects will linger and may even become permanent side effects, or maybe things that improve initially, but then down the road develop. And so you can have chronic bowel or bladder difficulties, sensitivities, certain foods that trigger diarrhea, occasionally more serious problems like hematuria or bleeding with bowel movements as well. Patients can rarely, but occasionally can have bowel obstructions, stricture formations, fistula formations from treatment. Other things that I always warn patients about or talk about are insufficiency fractures. They can be seen in the sacrum. Lymphedema, particularly if there was some component of surgery involved. Vaginal stenosis and sexual dysfunction is a fairly common issue after treatment. And so many of us do recommend use of a vaginal dilator, a vaginal wand to help prevent that, or pelvic floor physical therapy for these patients. Many of these patients are young, so I do always mention in the young patients to expect a premature menopause and ovarian failure and infertility. There's a small proportion of these patients who may be able to undergo displacement or transposition of their ovaries before treatment out of the radiation field. But the majority of patients may not be eligible for that and aren't going to have premature menopause. And then finally, the other reason with the other thing with the young patients is that they hopefully are going to be cured and live a long, long time. And so there is a small risk of secondary malignancies related to the radiation. So I warn them about that. And I think the only other thing I would say about toxicities is that, at least in my experience, and many of patients with cervical cancer are smokers. And so to try to help motivate them, not just for their overall health to quit smoking, but toxicities tend to be worse in people who are smoking. And so I use that as an added incentive and go over that to try to encourage them and assist them in quitting smoking.
Great, thank you. And so, Dr. Chino, how would you set up this patient, and what dose and fractionation do you commonly use? How does that change if they're node positive?
So I think you'll see there's a lot of differences in how people set patients up. And essentially, I think you have to look, a lot of this is based on your own practice, and simulation techniques really are place dependent. And I think one of the feedbacks that we have is when we look at imaging for patients, that feeds back into how we set up our patients. I actually use fairly minimal immobilization, because I don't feel that most of the movement here is with organ motion more than anything else, rectal filling and bladder filling. And so I actually immobilize these patients with a wing board. I don't actually use any more advanced techniques, although I don't think it's wrong to do that. I also don't use a whole lot of contrast. It kind of depends on what kind of diagnostic imaging we have. If we have good diagnostic imaging, I think we can usually translate that into it. It's certainly not wrong, though, to give them contrast. I often will get an MRI though, because we're fortunate enough to have an MRI sim at Duke, so we actually usually do that. It is probably not strictly necessary, but what it does help is to really see the internal anatomy more than you can see on a CT scan, and we'll probably cover that a little bit with brachytherapy. So it actually my sims tend to be fairly straightforward and fairly quick. And I don't know, do you want me to talk about dose and fractionation as well? Skip forward to that one, or
Sure.
or not?
Yeah.
So for most patients with
bladder empty?
shoot. So I don't tend to do that, mostly because I feel, I mean, I know that different people do different things. I think it's certainly not wrong to do an ITV, which would be to sim with a bladder full and bladder empty. I actually think it's kind of hard to have a patient come in with a full or empty bladder during treatment. It's kind of hard to make that actually happen. And actually for cervix, I feel that sometimes it's full and empty rectum. That's probably more important. And that's actually super hard to figure out, how to get patients to do that. So more than anything else, I tend to look at the images and try to visualize what's the possible excursion of the cervix ant and post. And I always err on the side, particularly in the low pelvis, of covering more because, skipping ahead to the next question, I'm usually doing 45 gray to most cervix patients and 25 fractions. And what the most important thing is not to miss the primary tumor. So I think if you're using IMRT or more advanced techniques such as IMRT or VMAT, then continual reevaluation of the tumor volume with a CBCT is going to be particularly important. I guess I'd actually like to hear what the rest of the panel does, because I think there's a lot of variation here about it, but the most important thing is not to miss. And so if you do, the one issue I have with ITVs is, when reviewing some of these films sometimes with the NRG, is that sometimes people do have an ITV of a full and empty bladder, and that's great. You can see some excursion there, but then they put very, very tight margins on that ITV. And I feel like that's not entirely, I worry about that, because I worry that you can control bladder to some extent, but what you can't really control is rectal filling. And I worry that a patient comes in with a very different rectum and the tumor can move a lot, and being too tight really is a risk there. So in the low pelvis, again, we're relying on brachy to boost this. So I'm not doing anything fancy to the cervix itself. We're going to boost that with brachy. With nodes, I'll often use an SIB or a simultaneous integrated boost. And oftentimes based on small bowel doses, like we'll go up to 65 gray in 25 fractions. It's fairly aggressive. Some people would stop at 55, and I think that would be fine. But I think if we can get the bowel D2CC to under 55 gray, an SIB I think has been fairly tolerable in our experience up to 65 gray. So, but everything happens in 25 fractions one way or the other, at least at Duke. But I think Kristen and Matt will both have very different answers to that question.
Yeah, I was going to see if you guys had any comments.
I tend to do an SIB too. I most commonly use 55 gray in 25 fractions. I will, if there's a little bit bigger node, depending upon its location and bowel, I will occasionally go up to 5940. I tend to stick at 2.2 though, so if I'm gonna do that, it then just becomes a nodal boost for the extra 1 or 2 fractions. But most commonly 55. I also tend to, if we have nodes that are more than 2 centimeters, we usually laparoscopically debulk those nodes before we do radiation. So most of the nodes I'm treating are under 2 cm to 55 and 25 fractions.
For me, I'm routinely doing integrated boosts as well. The nice thing is that helps you condense the overall treatment time as well, that you're often limiting yourself to those 25 fractions and giving a definitive dose to those nodes. My routine dose off trial is 5750 to 60 gray. If it's a bigger node, then I'll try to go higher as well.
Great, thank you. And so as many patients do, her bleeding improved within the first week of treatment. She had some mild to moderate diarrhea controlled with Imodium and some fatigue that improved. And so our next poll question is, what is the clinical benefit of brachytherapy in this disease site?
Sorry, is that open to the panel? Or is there a poll?
There
No.
should be
There we go.
now.
Yeah, now,
Perfect.
now it's open.
I don't want to answer and have you guys cheat.
Are you able to see
All right.
the results, Chris?
Yes, thank you.
Okay, great.
And so it looks like most folks thought that there was both a local control and survival benefit. And Dr. Bradley, what are your thoughts on this poll question?
I agree. So there have been a couple of database analyses, both SEER and NCDB analysis, that have looked in the SEER case at the inclusion of brachytherapy or radiation without brachytherapy and showed an overall survival benefit. And then in the NCDB analysis, it looked at brachytherapy compared to escalating or giving the boost with external beam techniques such as IMRT or SBRT, and found a benefit in the and improved outcomes in the patients who got brachytherapy. It's really what I tell my patients, you know, it's a safe way. We're somewhat limited on how much dose we can give to the whole pelvis, because when the radiation photons come in, they traverse through your normal tissues, through the bowel and the bone and the bladder. And the brachytherapy is really a way of giving the radiation from the inside out. And it gives much less radiation exposure to the normal tissues and allows us to boost or give higher doses to the cancer in the cervix to be able to eliminate that and cure that while reducing side effects and radiation exposure to normal structures.
Yeah, I definitely echo what Kristen said. I think that, you know, databases would show there's a survival benefit. You know, technically, actually, though, prospectively, there has ever been a randomized trial of brachy versus other kinds of boosts. It's mostly the fact that boost protocols have really not shown a superiority to brachytherapy, number one. And maybe, you know, actually just looking in the Red Journal just in the last year, you can see a prospective SBRT boost protocol from Kevin Albuquerque showing a very high rate of toxicity. And so not only is it improving our control rates, it's actually reducing our toxicity rates. So I think that's another important side of this as well.
There's a couple pictures here, if you can pull them up, JP. And Dr. Harkenreiter, could you discuss sort of the evolution of brachytherapy over time and what you see shown and what you utilize in your practice as far as 2D versus 3D plan?
So on the far left, we're looking at just an AP X-ray with a brachytherapy device in place. I actually I didn't train that long ago, but I was trained by somebody, and this is how things were planned. So the central aspect is called the tandem, and then on either side you have the ovoids. This is one of several different applicators that can be used. But essentially the central tandem goes through the cervix into the uterus, and the ovoids sit in the vaginal fornices, so up next to the cervix on either side. And then you would load these devices with with a radiation source. For decades, it was a low dose rate source that would sit in those applicators for a period of 2 days or so per implant and slowly emit the radiation over time. And again, kind of like how we talked about the staging required a universal language, that's where those points come in that you see marked. So point A is a very historical point going back to the 1930s. That's about 2 centimeters up and 2 centimeters over from any one of your surrogates for where the cervix was located. And you could calculate where that dose was and have a common language of all of our implants across the world. Moving over to the center is a CT-based planning, where now you're using 3-dimensional imaging to see your targets, but more importantly, probably the organs at risk as well, so that you can really see what the anatomy looks like on the inside, where the applicator is, and just like we would an external beam case, draw out what you want to treat, the cervix, the gross disease that you see or feel, and then draw out the bladder, rectum, sigmoid that you want to spare. And in scenarios like this is a different applicator called a ring. So rather than those 2 ovoids, there's a circular ring that sits high in the vagina. And then this type of device will connect to a machine that will send one single seed into each of those devices according to a computer-generated plan that you as the physician have generated with your physicist or your dosimetrist. And you've really optimized, so found the best balance of treatment of your target and sparing of your organs at risk. And then moving over to the far right is what was commented earlier is the MRI really gives a beautiful view of the soft tissue there. And you can further kind of customize your targets for exactly what you were seeing at diagnosis and how the disease has regressed over the course of the external beam. The CT and MRI do very similarly when it comes to organ sparing, but you can get a better dose or better delineation of your target with that. And then our applicators have similarly evolved that we can maybe use a couple needles that may go through that ring that it will help pull the dose out to that left parametrium, for instance, in the disease that we're seeing in that image there. So we've continued to evolve with our imaging and our applicators, and then the data supports that our ability to cure these patients goes up with those more advanced modalities.
Right. So we, consistent with many ideas, we treated to 45 and 55 gray, 25 fractions with a 5 fraction HDR brachytherapy boost. Should be a PET CT.
To interrupt, there's 2 great questions in the chat. Are there any specific scenarios you would consider high versus low dose rate brachytherapy for cervical cancer? Start with that one.
So I would say the way that I approach this to any audience is simply delivering brachytherapy is step 1, I think. We can get fancy with MRIs and better applicators, but simply doing it, I think, is better than trying to come up with a plan with other external techniques. The high dose rate, more and more of us are being trained specifically in high dose rate as opposed to low dose rate, because it offers us more flexibility with what we can accomplish with the patient's treatment, meaning that we can optimize to find a better balance for the patients. Low dose rate has greater radiation safety concerns that we have to keep the patient inpatient, so their healthcare providers while inpatient, to the doctors, any family members are limited in their time, that it's a bigger radiation safety issue with low dose rates. So those are the 2 main reasons why most centers in developed countries are are performing high dose rate predominantly. But if low dose rate is what a center has access to, then it is great care for a patient, I think.
Great, and it looks like the next question is, how do you target disease that's posterior to the pubic symphysis with brachytherapy?
So this can be a challenge, you know, because different diseases can be in different locations for every patient. To be posterior to the symphysis, you're probably talking about disease that's kind of coming up to almost the trigone of the bladder, which can be a challenging location. Oftentimes what we're doing in these kinds of situations is looking to see if, so sometimes I don't usually often use tandem rings that much, but sometimes I will if I feel like loading the anterior portion of the ring would get it. And so sometimes that's the case, but maybe more often than not, we're placing a row of needles in that area. If it's truly up and over, there are very occasional situations where you just can't get at it one way or the other. And that may be the only situation where you might use an SBRT boost. But I think in most departments nowadays, if you have good imaging capabilities, or at least a lot of, you know, tertiary centers, and you have a good, well-developed interstitial program, you can usually get needles into a lot of locations, like curved needles or whatever, to kind of get into an area where you might. Really, truly retropubic symphysis disease is pretty rare. It's not places where you usually see things, but sometimes you will see base of the bladder issues, and it can be difficult, and you have to cancel the patient that, you know, there's a possibility of bladder injury in that sort of a situation. But
All right, and I think this is a video. And so on the right, you can see her pre-treatment PET that we saw before, and left as her post-treatment PET with a really nice treatment response. And so on follow-up, she had no evidence of disease and surveillance, but then began having painful bowel movements and intermittent rectal bleeding, and a sigmoidoscopy was performed, which showed this. And so Dr. Bradley, what do you think is going on? And you talked about counseling your patients, but in your practice, how you manage these situations?
Yeah, it looks like to me that they're having some chronic late radiation effects of radiation proctitis that you can both see the changes on colonoscopy and rectal bleeding as well. One of the things that I do to try to prevent this from happening during treatment planning is pay attention to the rectal and sigmoid doses. There are good guidelines that have been kind of established based upon large cohorts of patients treated mainly in Europe that gives us guidelines for what dose constraints to put on the rectum and the sigmoid, where you document your external beam dose, and then you document the dose that the sigmoid and rectum receive during each brachytherapy fraction, and that gets summed and totaled. And you want there, you know, numbers that you want to try to keep below to minimize the risk of having proctitis. There's actually data showing that there is successful reduction in proctitis risk and fistula risk if you achieve those dose constraints.
It's a good question. Do you know of any differences in long-term quality of life between what I assume is a brachy boost versus external beam or SBRT boost?
yeah, I'd say that the few cases that we've had where external beam boost has been necessary, usually because of patient refusal or some other issue, the incidence of this kind of thing happening is much, much higher. And I think that's echoed by the results of the recent prospective trial from UT Southwestern that these kinds of complications are much higher. They actually used to be quite high with LDR techniques in our institution. You know, we would have 15% risk of grade 3, sigmoid rectal toxicities. I think one of the main advantages of going towards an MR-based or CT-based program is that our rates of this have dropped really, dramatically low. So the reason so the management of this is usually for bleeding, you can go to APC or plasma coagulation from GI specialists, or in other situations, you might even do HBO or hyperbaric oxygen therapy, which is a big time commitment. But fortunately, our rates of these have gone down significantly low. Like used to be, so the old adage was that if you're not treating if you're not seeing grade 3 toxicity in 15% of your patients, you're not curing enough cervical cancer because you're being too shy. But I think that adage is now out the window, because I do think we can achieve a much lower rate and still cure a good portion of our patients without this kind of toxicity. So
I think the other thing that has helped with this too is that, at least I think I'm probably the oldest of this group, and so when I trained, if someone had perimetral disease, they automatically got boosted. So if they had early perimetral 2B, you always went to 50.4 gray. If they had more extensive perimetral disease, 3B, where it extended out to the sidewall, you gave them 54 gray. And really what that means is the sigmoid is getting 50.4 gray or 54 gray prior to even coming to brachytherapy. And I think most of us who do a lot of gynecologic cancers very rarely give perimetral boosts now. We usually do 45, and then with external beam, I should say, and then we use, if we need to boost the perimetria, with needles, hybrid interstitial techniques that gives, where you can cover the perimetria, but you're actually giving much less dose to the sigmoid with that approach.
Our ability to individualize treatment for the patient in front of you now is so much better and supported by the data versus kind of a one-size-fits-all approach like the other panelists were describing. And I think that really makes cervix cancer very fun and rewarding to treat, because it's problem solving for each patient that walks in your clinic, and it's really cool.
Great. So moving on to the next case. So this is a 26-year-old. He self-identifies as male. He has type 1 diabetes. That's well controlled. He presented initially with right thigh pain with no other symptoms. And so to Dr. Gunther, if they're still tuning in, for a patient in your clinic, what are the components of the HPI that are important to you?
Yeah, well, I think it'd be different in my clinic than maybe in a generalist clinic. You know, a 26-year-old presenting with right thigh pain, honestly, my first thought would be, is it some type of musculoskeletal injury? Certainly more common than something malignant. If they're coming to me and we're kind of suspicious of a mass or something malignant, then you know, I'd ask about fevers, night sweats, weight loss, which are things we worry about with lymphoma. Also for both things malignant and non-malignant, you want to know if there's any associated neurologic compromise, components like how long the pain has been there, how severe the pain is, things that make it better or worse. So kind of general medicine type things.
Great. And the rest of the HPI was really unremarkable. And the physical exam does reveal this firm, poorly mobile, non-painful right thigh mass, and there's no skin changes, no other palpable lymphadenopathy. And so Dr. Tao, could you elaborate on your comprehensive nodal exam?
Sure. You know, so I probably would just focus first on kind of the region right by the mass. You know, I'd just palpate to see if there's any, you know, popliteal lymphadenopathy, any inguinal lymphadenopathy on, you know, the the right side, and then I would probably move on to, you know, the contralateral side, the left side, and see if there's anything that's palpable. As far as a comprehensive nodal physical exam, then I'd probably just start, you know, kind of head to toe again, kind of just get a sense of any occipital lymph nodes, neck lymph nodes, supraclav, infraclav, axillary lymph nodes. And then, you know, for lymphoma, you want to also, you know, when you're doing your abdominal exam, kind of evaluate the spleen, if there's any splenomegaly. I think that's about it. I think, you know, luckily all of our patients get, you know, staged with PET scans. And so those can be really sensitive to pick up even really tiny nodes that you can't feel on physical exam and show whether they light up and are FDG avid.
What, Chris, one physical exam tip that I found pretty useful, I learned from one of our GI surgeons, Dr. Herzig, is for the groin exam, with the patient laying supine, have their legs drape over the table, hang off the table, instead of that pulling out that leg support thing that's on the table. And it brings the groin nodes more superficial, brings the groin more superficial, more anterior. And I've noticed that it's you're palpating through less soft tissue, feeling the nodal regions there.
That's great feedback. This is a video of an axial T1 post-contrast MRI. And Dr. Gunther, would you be able to comment on what you see?
Yeah, so it looks like there's an enhancing mass, both surrounding the bone and involving the bone. It looks like the marrow is involved as well.
Perfect. So a biopsy was performed. You can see the needle entering the mass via ultrasound guidance. And this is the path report. I believe there's a question. And so, Dr. Tao, what kind of things are you looking for on the path report?
So, you know, especially with lymphomas, they can be so heterogeneous. The pathology is really, really critical. That's something like that I usually start off with first, to just kind of review and read all the kind of detailed comments, to kind of get a sense of, you know, how aggressive this potentially may be. For diffuse large B-cell lymphomas, you want to kind of get a sense of, you know, the cell of origin, which we see in the comments here that they already kind of note for us that this is a germinal center type. You know, they can also be, you know, the activated B-cell types, which typically can be more aggressive. You're also looking for some protein overexpression, BCL2, BCL6, and MYC. And then they're noting here too with cytogenetic studies, where you're looking at actual chromosomal translocations on fish, whether the patient has a quote unquote, you know, called double hit or even triple hit lymphoma. And that's when you have MYC translocation with either BCL2 or BCL6, or, you know, potentially all three. Oh, is it? Okay. Sorry about that. Yeah, I see that. I'm going to mute myself.
Thank you. And here's the PET-CT that was obtained. And you can see the correlate with the MRI, the abnormality in the right thigh. And Dr. Navavizadeh, would you be able to describe the staging system, which is, I think, touched on in the last case as well?
Yeah, so I mean, the Ann Arbor staging system for lymphoma is the same between Hodgkin's and non-Hodgkin's, with, you know, stage 1 being a single site, stage 4 being diffuse involvement. You know, involvement of solid organs, diffuse involvement of a solid organ is also considered stage 4. And for these situations with bone lymphoma, it can get kind of tricky. There is another letter that we add to the staging criteria, and that's the letter E. stands for extranodal, and that's for a lymphoma that's arising in a extranodal tissue, such as the bone or the soft tissue or the salivary glands we see quite commonly. So for this patient, he's got one side of disease, although quite extensive and involved, with, from what I remember, the PET scan, as I actually know this because it's my patient, from the PET scan having no other sites of disease other than the thigh. So I would stage him as stage 1E lymphoma rather than stage 4.
And so the next poll question is, what's the next best step in management?
Yeah, I'll just add that, you know, with extranodal lymphomas, the staging is really tricky, and I always struggle with it because I just feel like, you know, a patient who has, for example, just, you know, knee involvement of the femur or the tibia, that's then technically stage 4 because you have 2 sites of bone involvement, but I don't feel like they would necessarily behave like a typical stage 4 patient. It's a huge spectrum.
All right, so it looks like most folks would have chosen to do R-CHOP and consolidated radiotherapy. So, Dr. Gunther, would you be able to comment on your treatment approach in this case, and how that might change if this were a non-bulky inguinal DLBCL?
Yeah, so I think that's appropriate. You know, we would feel pretty strongly about consolidating this patient with radiation therapy given the bulky disease and the bony disease. So I think R-CHOP plus consolidation radiation therapy would be my approach. If this patient, let's say that they were overall really low risk, a younger patient with small non-bulky disease, stage 1, without an elevated LDH, you know, and all sorts of kind of favorable risk factors, there's increasingly data that says that you can treat the patient with 4 cycles of R-CHOP or 4 cycles of R-CHOP plus an additional 2 of Rituxan alone, and they have equally excellent outcomes. And so I think there has been a bit of a shift from our standard kind of 3 cycles plus radiation therapy for favorable patients to some who are being considered for the chemotherapy alone approach. I don't know if the other panelists have any comments.
Yeah, I would totally agree. You know, before it was kind of just, you know, you would do R-CHOP with 3 cycles and make sure to do consolidated radiation therapy versus R-CHOP with 6 cycles. But now that there's shortened kind of abbreviated chemotherapy, you know, that could be a good strategy too.
Yeah, absolutely. I'm similar to echoing that. I mean, a lot of things too kind of depend on the disease site that we're treating and whether or not we want to add the morbidity and toxicity of radiation, or should we stick with the morbidity and toxicity of one therapy with chemotherapy. So that's definitely something to keep in mind. For in this situation with the thigh mass, the morbidity of the treatment is relatively low in comparison to other sites of the body that you can be treating for lymphoma.
All right, and Dr. Nabavizita, how would you describe this treatment response?
So he had a great treatment response. I mean, this is, I'm assuming the left is his pre-chemotherapy PET. With how his MRI looked and how aggressive his MRI looked, I was surprised that he didn't have more FDG avidity on his PET scan than he did. But nonetheless, he had a good course of R-CHOP chemotherapy, 6 cycles he received. Now, whether or not that's the correct number of cycles or too much is, I think, a matter of debate for a lot of medical oncologists and radiation oncologists. But he had a, you know, what looks like a complete response to therapy. You can kind of see the uptake of the liver on the right scan. And although I don't have the actual SUV measurements, you know, for a Doble 3 lesion, which we would typically classify as a complete response, we're looking for the uptake of the mass to be less than the uptake of the liver, and it seems to be the case. Okay.
Thank you. And so back to Dr. Gunther, how would you set up this patient for treatment? And are there any devices you could use to protect this young male patient fertility?
Yeah, so when you simulate these patients, actually sometimes our med oncs send them up front, which is really helpful. Sometimes with soft tissue disease, it's really nice to simulate them up front, then you know exactly where that disease was. If you don't have the benefit of that, then I think making sure that the treatment that you plan is that's delivered. So you know, indexing, immobilizing the foot is very important to make sure that that leg rotation is the same every single day. We usually use just a lower back lock to try and support the leg and again, keep it in that same position daily. In terms of genitalia and testes, it's always tricky. Distance is your friend. So we try to, you know, immobilize the scrotum or push the scrotum away from the treatment field as much as possible. And then, you know, some people use clamshells. Sometimes you can just use kind of generic shielding. I usually do in a patient who's young and interested in future fertility, have them undergo sperm banking if they haven't already been started on chemotherapy. I think that's a nice backup plan. And then on the first day of treatment, even with the shielding, we will often use TLDs just to confirm, to get a better estimate of the actual dose that's being delivered.
Great, that's really helpful.
Yeah, I love how our field is very, you know, technology based, but then sometimes we also rely on tape, like get creative with towels and tape and make sure to create distance between what we want to treat and what we want to avoid.
And so, Dr. Navizita, would you describe what your thoughts were when doing?
Yeah, so I mean, involved site radiation therapy still holds in this case as well, where we're treating the initially involved site of disease and utilizing his pre-treatment images. And thankfully, he had a good host of images with contrasting SMRI and PET scan. We identify where the tumor was initially involved with an adequate margin, and basically conform that. You know, the bulk of his thigh changed a bit between pre-treatment and post-treatment. So you kind of adjust for those variations and tailor the treatment to obviously the person's anatomy currently.
Right. And so in summary, we'll actually skip this slide. It looks like we are out of time, unfortunately, but we used a 3D approach, spared a strip of skin for lymphedema considerations, and had a mild treatment-related sequela, and did quite well overall.
Thank you. Our last case was an endometrial case. Unfortunately, we ran out of time, but we had such great discussions during the previous 3 cases. If you could go up 1 slide or 2, you can see endometrial case, their external beam radiation therapy. And if you go 2 slides down to their brachy, so this is a vaginal cuff brachy plan. We want to thank you for coming. We will be sending you a post survey. That'll be Rover Post 4, not 3. And so you'll get that in your inbox. Next slide. You can always contact us on the website, radoncvirtual.com, or you can contact myself or Archie Pullum. Next slide. The next session will be breast and sarcoma, which will be August 6th, same time, similar place. So make sure to sign up for it, because we will send you the code to be able to watch afterwards if you aren't able to make it. Next slide. We are putting together on September 10th a networking session, which will include breakout rooms with faculty and residents from around the country. So please register now, and we're trying to limit it to M3 and M4s to dedicate some time for them. Oh, lastly, yes, on the website, if you click around on virtual clerkships, there's all of the virtual away rotations that are available on the website. And then there's also meet and greets that are on the website, and I'll continue to update those as they come in. So watch out for those. And I don't know if the panelists have any extra time. I'm sure everyone has clinic and such, but I don't know if you have any advice for medical students or if the medical students have any questions.
I would just say it's a great specialty. You know, I know there's a lot of hype right now about, you know, the future of radiation oncology from a matching and interviewing perspective, but fundamentally, you know, this is a exceedingly rewarding specialty to practice in. And I think that really should be the most important thing when deciding what to do. I think if this sort of aligns with your passions, taking care of patients and offering them really a truly unique therapy that isn't going away despite any, you know, any narratives to the contrary. I think you've made a very wise choice, and you know, any questions, obviously feel free to ask me about anything along about what's going on at Duke and just the specialty in general.
And Chris is actually on vacation. We just don't have residents out on Mount Hood on a work day, just so you guys know.
If anybody has any questions regarding the application process, residency, you have several residency program directors here on the panel, so we'd all be happy to kind of help guide you through those things. And if there's any concerns about the future of our specialty, I'm sure that you know, everything waxes and wanes, and there's also a lot of opportunity comes around this time. So I think we all love our specialty and are strong advocates for those who are interested. So.
Great. Well, thank you everyone for coming. Special thank you to our panelists as well as Nav, who has helped to coordinate all of this and all of our Rover events, and JP and Chris, who are wonderful guides through these sessions. So please, we'll send a post survey as well as the emails to reach out to any of the panelists on the session. Thank you, everyone.
Thank you.
Take care.
Thanks. Have a good day.
Guys.
Take care.
Thanks. Have a good one.